Good afternoon, everyone. Welcome and thank you for taking time to join us. We are very excited to present the Black Birthing Matters Part 2 conversations. So hopefully you've been able to either participate or catch up with the Part 1 conversation. It is stored on our YouTube channel, so feel free to catch up if you need to later. But we are so excited on behalf of the Charlotte Maternal Child Health Work Group to welcome back this panel of really wonderful folks that are in our community in Charlotte and are always happy to join the conversation around Black maternal health. So we're super grateful and we'll be introducing those folks in a few minutes here. I do want to also thank our partners who have made this panel discussion possible today. So briefly, the Maternal and Child Health Work Group has a couple different functions. We are faculty and students at UNC Charlotte who are really committed to trying to hold space for a bunch of different opportunities, including research and practice, collaboration, that's kind of how this has been facilitated today, service, and dissemination. So getting the word out about the work that's happening with our research in our community and trying to amplify those opportunities. If you're interested in joining the Maternal and Child Health Work Group listserv, if you heard about this event from other outlets, we'll be dropping a link in the chat for you to be able to sign up and stay connected with us. We have monthly conversations. This is our November conversation around topics related to maternal and child health. So if you would like to get involved or lead one of these sessions and communicate about the work that you're doing, we would love to hear from you. So please stay connected. I also want to again, promote and just let you all know of this community resource that exists. We have Dr. Cobb on the call, and she's been a leader in this space with developing a local resource that is tailored to our population here, our local population here, but the content is really far-reaching in terms of the information that's provided on there. So if you're not in Mecklenburg County, you might take a peek at this resource and see the kind of information that we're communicating, excuse me, to the community. So check that out, Mecklenburg Birthing Connections. And we are almost, let's see, I think we're reaching our attendance, what was expected for today. So I want to pull this slide up for y'all and let you know about a couple of resources that will be highlighted today. We will send all of this out via email at the end of the day, along with the recording of today's session. And we have Mecklenburg Birthing Connections, which I just previewed on the last slide. We have the Queen's Collective Birthing. Our moderator today is Racquel Washington, and she is going to tell you a little bit more about herself in a little bit, but if you want to stay connected with her, that's how to do it. Mother of Ease, we have Kris Elle on the call today on our panel, and she'll be happy to talk to you about the services that she's providing locally. We have City Block represented by our panelist, Nicole Parchment, and then we have Mecklenburg Public Health Department, which we would like to also remind you all exists as a resource in our space. All right, so we have a couple of action items for y'all. We would like you to please drop in the chat who you are and where you're from, which space you're representing today, what's bringing you to the table. Anything that would be helpful for the panelists to know who is in the space and joining the conversation. The other thing I want to draw your attention to is today we'll be using the Q&A function on Zoom. So you'll find that in the toolbar, the Zoom toolbar, usually located at the bottom of your screen, depending on what device you're on. That Q&A function will allow you to drop questions for the panelist in to that space, and then you can upvote. So if somebody puts a question in that space that you would like the panelists to answer, please use that upvote function. That'll help us to prioritize questions that folks really, really want to have answered today. All right, y'all. Thank you so much for dropping in your information in the chat. Hi, everyone. So lovely to see you. My name is Alicia Dahl. I am a co-director with Dr. Lorenzo Hopper, who's on the call. I'm an associate professor in the Department of Epidemiology and Community Health. We also have several of our faculty and students involved in this work here on the call. So please take a look at the chat and see who you're connecting with today. Without further ado, I am going to send things over to Racquel. I'm going to stop sharing here. Racquel Washington, take it away.
Hey, everybody. Thanks for joining us today. I'm happy to be here with you all. Like Alicia said, my name is Racquel Washington. I am a reproductive justice birth worker. I've been working in this space officially for about the past 6 years. And I primarily support families navigating perinatal and infant loss and all the ways that their parenting and family building journey unfolds. We are going to start out with a brief recap. And as we go through and get started, we will have our speakers give a brief introduction. We actually spent a lot of time in our last session telling all the things about all of us and what we like to do, why we come to this work. So I urge you to check out the recording from last session that's available on YouTube if you have not already gotten an opportunity to. So last time we were together, we talked about Black Birthing Matters. We talked about doulas, OBs, and midwives and how they provide care. We talked about ways that they work as a part of a team to support clients with various needs. And we also talked about how they can communicate with one another. We gave some information about where you can find a doula, where you can find an OB, where you can find a midwife, as well as a little bit of information about how you can pay for each of those services. So again, if you haven't already gotten a chance to, I urge you to check out the recording and then feel free to follow up with any questions. This is part 2. So we did ask you guys to submit questions that you wanted us to answer. And if there's a desire or need, we can continue with this answering questions that you all have. So without further ado, we'll jump right in and round through our quick introductions. And I'll start out with Kris because I have Kris first.
Hi, everyone. Thank you for being here. My name is Kris Elle. I am a mother of 5, a certified doula, certified lactation counselor, and the founder of Mother of Ease, a Black maternal and family health company whose principal focus is the birthing experiences of Black folk. I am based here in Charlotte, North Carolina, but I provide my services nationwide through travel support and virtual support. And I'm excited to have this conversation with my colleagues and talk a little bit more about how we work together and answer any of your questions.
Thank you. So glad to be joined by you, Kris. I'm just noticing I have that same flower pot. Yes. Okay, Pam.
Good morning, everybody. My name is Pamela Cobb. I'm an OBGYN. I've been with Atrium for the last 20 years. My practice is the North Park OBGYN. I excuse my dog growling. And my practice is largely women of color. And my expertise is with group prenatal care and improving the birth experience for women of color.
Thank you for joining us today, Pam. Nicole.
Hi, everyone. My name is Nicole Parchment. I am a midwife by training. I've been doing birth work for about the last 11 years between nursing and midwifery. I am a Black mom, an activist, and right now I am working with City Black Health as a clinical lead for their pregnancy program. And I'm still doing birth at the bedside in the hospitals in the Triad area. I am based out of Charlotte, though, and I'm just very happy to be here. Thanks for asking me to come back.
Thanks for joining us, Nicole. All right, so we all know who's in the room. I see you guys' introductions are dropping in. I see some people that I'm familiar with. I hope you guys see some connections that you want to make. So we're going to get to the nitty-gritty. So our first question, we want to talk about induction versus physiological labor and the difference between how OBs and CNMs think about this. And then once Nicole and Pam answer that question, I'd like you to jump in, Kris, and talk about how doulas are able to support in both processes as well. So Nicole, Pam, whoever wants to take it off.
I will start just briefly, and Nicole, jump in whenever you want. If people in the attendance have ever had a baby, of course, at some point, a pregnancy theoretically is supposed to go to 40 weeks. Everybody gets a due date that is 40 weeks. And traditionally, we have allowed moms to go into labor on their own at 41, 42 weeks, which is called a post-term birth. There have been more and more and more information about inductions versus physiologic labor and which is better. I will tell you that for women of color particularly, we know that women of color suffer more C-sections. The C-section rate is much higher than their white counterparts. And there may be a lot of reasons why that is. One of the things that we are trying to do to decrease C-sections is to support the onset of labor spontaneously and the labor process spontaneously. So we often get into a discussion about which is better. Inductions, one of the things about Black women is that we have conditions that sometimes necessitate an earlier induction of labor. So Black women suffer higher rates of hypertension, higher rates of preeclampsia, and often that results in a conversation about a medically indicated induction of labor. So sometimes a mom comes in and the blood pressure might be elevated and your OB might say, oh, you know what, it's time to have the baby at 37, 38, 39 weeks when mom was prepared for a 40-week delivery. So we have to start thinking about how we start that conversation before it's time to have the baby. How are we discussing what's the propensity, what's the doc's inclination to allow you to have spontaneous labor, to go past your due date? There are lots of pros and cons to discuss, which I can go into, but I would definitely like Nicole's opinion on this.
So thanks, Pam. That's a really good point that we really have to start talking about induction and what that means before we get to it. And I'll kind of get to that point in a second. But when I think about physiological birth, we just have to think about the fact that our bodies are like intrinsic. We have this intrinsic function to be pregnant, go into labor on our own, and then have a birth. Like that can happen outside of the conforms of medicine, right? That's happening at home in birth centers, that sort of thing. So the midwifery model of care at its foundation really supports physiological birth. And the way that obstetrics has changed in the last 10 years or so is that really and truly, they are trying to also support that as well, right? Trying to, like Dr. Cobb said, really trying to let people go past their 41 weeks, 42, and then also bringing into the picture that, yes, there are some risks to that, but that risk doesn't outweigh the benefit, right? And so at that point, we can start to do other things like just do more surveillance and educate parents of what is a danger sign and what's not, and when they can, kind of indicate that maybe it's time to go towards an induction. Ways that midwives support that is just one, knowing, like having the information of what is normal and what is not normal. And so when we start to deviate from normal, then we can start intervention versus starting with the intervention, which is the induction of labor. Some examples of that is that if we have a person, it's your first pregnancy, then it's normal to go past 40 weeks, right? It's normal to go to 41 weeks or so. And like I said, just add a little bit more surveillance so that we know that baby's still doing okay. Another example of that is we also wait. One thing that midwives do or that we talk about is watchful waiting, like quieting that impulse to rush into labor or birth, right? And so if we look at the full picture, this is normal because this is their first pregnancy. They haven't went into labor on their own, reassuring the person that it's normal, and then reassuring everyone that it's okay to wait. Some things we can do in the meanwhile is, talk about different exercises and things that support labor. They're not going to induce labor, but they support walking, resting, nipple stimulation, sex, hydration. These are things that midwives will typically tell you in the office to just prepare your body for a good labor experience. And also not warning people, but really discussing too that if you are having that induction at 37, 38 weeks, it's going to look very different than an induction at 41 weeks. Your body's more prime and ready to go into labor at 41 weeks than it is at 37. And so normal is going to look different at that point.
Thank you. And I heard both of you all mention education and starting a conversation. And I think that's a perfect entry point for Kris to talk about her role.
It is. So in my work as a doula, my favorite work as a doula is really preparing people, educating people early on. Oh, thank you. Educating people about and around not only their desires, like what it takes to get there, right? Because sometimes, people go into birth and many times they have a vision of what that will look like and what it will feel like, and how they want it to go. And I think even before we get into that space of, hey, I would like to have a physiologic birth. Well, what environment within and around does it take to support a physiologic birth? And even when we're planning for that, even when we're making the steps towards that, what are all of the other ways that birth can come about that we can talk about now, so that if we get to 37, 38, 39 weeks, and a different way of what we have expected and what we have planned for presents itself, we have the education that we need that doesn't really catch us off guard, that we're not making really heavy decisions in really heavy times. It's such a shock sometimes, right? When you're feeling good, you come into your doctor's office, your doctor checks you and they're like, hey, I'm noticing something that indicates that this labor, might not be a physiological one. We might need to medically induce. It's easier to navigate that kind of flow when we have exercised the education around it and we've prepared ourselves for that kind of process. So that is what a doula, like the perspective of a doula early on, is going to help you wrap around all of these possibilities and these realities, and get really granular too. When I hear induction, I think, well, what's the method of induction, right? And showing people pictures of what that looks like. What does the Foley, catheter look like, and what might happen when it's inserted? And I think it's helpful to visualize those things ahead of time, just in case you find yourself in that space. And also so you can prepare yourself for what might be grief of the way that things have unfolded for you, if that wasn't your plan. And then before all of that, before we even set our minds on, physiologic versus, medically managed, we have to really hone in on those discussions about who is my provider of care and what is my birthing context, my birthing place. So because certain choices, certain things that we lean into, the way that we want our birth to express itself and the way that we see our birth progressing, it really does matter who is taking care of us and where we are. Certain ways of flowing in birth work in certain contexts, and different people manage things differently. And so it's important to know, like, who you're with, who are your providers, and what are the practices that they hold, and what are the practices that the hospital holds. So it's just important to have a lot of conversation, and keep yourself educated about possibility, so that you can prepare if it unfolds how you want and how you don't want.
Thank you, and that was a good recap. Did you have something you wanted to add, Pam?
Yeah, I was just going to say, one size does not fit all. For every 4 women who want physiologic birth, I have 4 women who are like, when is this over? I cannot wait to have this baby. Induce me. Do you know what I mean? So it really does, you can't, not everybody has the propensity to want to go to 40, 41, 42. Some people are like, I've got stress going on. My job is, I got to get back to work. My mother-in-law is here. I need this done now. And so it really is again, it's not one size fits all. There are a lot of people who want the best thing and want the best labor process, but want it to happen at 39 weeks, not at 42 weeks.
Thanks for bringing that up. One, that is, care is not one size fits all, right? And I think that's one of the major goals of us having this conversation, so that we can understand all the different levels of care that are here. We've heard that education is really important, right? Both Pam and Nicole mentioned starting the conversation about the potential of an induction prior to that induction actually needing to happen. And Kris talked about how we would educate and kind of have some of those conversations. What are some ways that this can unfold? What are some questions that we can ask our providers? But then also really understanding how each of these providers provide care. What are they allowed to do? What aren't they allowed to do? What's typical of them? So that as we're choosing our care team and as we're creating our birth plan and deciding and determining where we want to give birth and how this happens, we can make that decision informed. Nicole, I see your hand up. I'm sorry I missed you.
No, you're fine. I just wanted to kind of add also that an induction doesn't mean like a death to your birth plan either, right? Like it just means that we have to pivot a little bit. And in my practice, one of the first things I do is sit down and go over like a birth plan if we have time. That's like Dr. Cobb said, like that's not always the picture. But just trying to stay as close to the original birth plan as possible. As one of the team members there in the room, maybe we can't have everything, but let's try to salvage what we can.
Mm-hmm. And I think, and as you were talking, we might need to level set. So can one of you all describe what an induction is and describe a few induction types?
You want to take that, Nicole? You want me to take that?
You can take it and then I'll add.
Okay. So an induction is, the onset of labor that is artificial or medically induced, medically starting the process of labor. There are elective inductions, which is the option of the patient. And then there are medically indicated inductions where either the mom or the baby are at risk with allowing the pregnancy to continue, and therefore there is a medical indication to end the pregnancy. So those are the 2 different things, elective versus medical. And then when you're talking about the induction itself, as opposed to spontaneous labor, which generally starts with the onset of contractions, the rupture of membranes, pushing, and then a baby, the induction can take probably 2 to 3 times as long as spontaneous onset of labor can, because we are taking a closed cervix, the closed mouth of the womb, and making it soft, pliable, open, and then starting contractions. So that entire process of softening and opening the cervix takes time, and it can be done manually with a bulb, meaning a Foley bulb in there, basically squeezing open the cervix. It can be done medically with hormones. It can be done with Pitocin in the IV. So there are all different options, and in general, it is based on what that cervical exam is on the day that you start. So if anybody has had an induction on, in the panel or listening, that an induction always starts with a cervical exam. We want to know how soft your cervix is, how firm it is, how high the baby is, whether it's even open, whether you've had a baby or not, helps know what kind of medicine or intervention your body is going to respond to. So I hope that in a nutshell explains what an induction is.
Thank you. Did you have something you wanted to add to that, Nicole?
I was going to say no, Dr. Cobb did so well. I don't think that there's much to add. When we talk about medical versus elective, though, there are some things that happen in the office. Sometimes, doctors or even midwives will offer you like something called a membrane sweep that can also help to soften a cervix and that sort of thing. But as Dr. Cobb said, your cervix has to already kind of be ready to do that and be open a little bit and that sort of thing. That's not technically an induction, but it is a way to kind of encourage labor.
Yes, thank you for adding that. And the process that Dr. Cobb described about the cervix softening and all of that, those are things the body would naturally progress through without a medically induced labor. So all of those things would happen on its own with the change of hormones in the pregnancy and then preparing for birth. Thank you. Kris, did you have something you want to add?
I do. I don't know how to use my little hand, but I'm using my real hand. So this conversation, sparked me in thinking about just how important, again, and how much I want to emphasize talking these things through ahead of time, especially when if you come into your pregnancy, into your birthing, or you're journeying towards your birthing experience with the intention of a physiological birth, or maybe you don't want pain meds for this process. If you choose birth at a hospital, number one, it's important to know your provider's percentage of how often are your providers patients induced, how often are they having cesareans. The same with the hospital system itself. If you know that you're more likely to navigate that type of birth, you really have to prepare your mind to manage that. And so it might change how you approach your pregnancy, how you're approaching your birthing experience, if you know that information and allow it to carry you. I've seen folks find themselves confronted with the birth that unfolds that's not what they planned for. And you can go in thinking, hey, like, this is what it's going to be for me, and this is how I'm going to do this. But when it all starts to unfold and it's intense, if we have not rooted ourselves and grounded ourselves in what carries us through, we might find ourselves really struggling in carrying through what we wanted for ourselves. Even just the management of it that's also a thing that sometimes I think we grieve, right? Like, the way that I handled this. And so if I have, if I've allowed myself the coaching ahead of time, or the inward, introspection ahead of time, I can, manage this thing that maybe it became something that I didn't expect. So ask questions and prepare yourself for what is birth, which is something that we cannot control. It does what it ought, and it's always birth. Regardless of the pathway, birth is birth, like, period. So, but what we can control is our mindset, our approach, and gathering the information that we need to really make informed choices and navigate it in a way that honors us and our family.
Thank you for adding that, Kris. And I saw a question come in, and I think this is a quick one. So how does somebody find provider rating?
I could speak to that a little bit. There is an app called the Earth app. That's IRTH.
Somebody will drop it in the chat.
Okay. And folks who are Black and Brown, who have given birth in various contexts in different states, it's like a Yelp type review system of what their care was like, what their experience was like. And I always lean on word of mouth, like, talk to the people that who have given birth recently. Within this community, we've got a lot of medical professionals here. Ask other medical professionals, have you worked with this person? And, just there's lots of information online. Different providers have bios, and I know Dr. Cobb has a lot of information online about her practice and how she cares for her patients. And so do your research.
All right. Thank you for adding that. We are going to jump in our next question, and I think we've already started to answer this a little bit, but I want to talk about what happens if labor is not progressing. So we talked about induction; it has a little bit to do with it, but I'd like to jump into that part of the conversation. What happens if labor is not progressing, and how do what's the difference between the way midwives and OBs think about this and address it?
Nicole, I'm gonna let you go first this time.
All right. Um, so I always start with asking questions, right? When we say things aren't progressing, my first question is, what stage of labor are we in? Because if we're in the latent stage, which is the first stage, it can take a pretty long time to get from 1 centimeter to the next. Sometimes it's a half centimeter in 2 hours, and we shouldn't feel laden by that, right? This could be normal for where you are in your gestation. Earlier, we talked about inductions. Inductions, just to get a cervix soft or ripened is what we call it, can take a day or two even before we actually get into active labor. Other questions I might add are, is this person's first baby, first birth, first vaginal birth? Because if they've had a C-section in the past that was scheduled, or maybe their baby was breech, that labor is also going to look a little bit different. So, like Dr. Cobb said before, there's no like one size fits all. You really have to make it patient-centered. Um, as a midwife in the hospital, sometimes I do feel rushed by OBs of this person's been 6 cm or 4 centimeters for 3 checks. Yeah, but they're also 35 weeks and we're inducing them. So we have to, wait to give people time. Other questions I might ask is, what position is this baby in? Because malposition can cause labor to stall. We could be at 6 or 7 centimeters for 2 and 3, 4 hours because a baby is OP or just not really in the pelvis in the best way. And the reason I bring that up is because there's different interventions that are less invasive if that's the issue that we're dealing with, right? And so from a midwifery standpoint, I feel like I'm always looking for the least invasive way to promote labor and push it forward. In some cases, something else is completely is happening that is medical. And when that happens, I just feel like as providers, we usually know. We usually see the writings on the wall. There are some red flags. I think it's important to bring the patient along, right? And so if you see those things happening, again, starting to have those discussions so it doesn't feel like a surprise when I come to the bedside and say, hey, I really feel like this needs to be the next course of action. Not in a way of like scaring anybody, but just discussing some of the different possibilities. And so people have time to think about it and discuss it with their partners and feel really confident about their decisions when we move to the next sort of intervention. And then in some cases, all of my tips and tricks don't work. I put people in all sorts of positions on their heads and we still aren't getting a baby out. That is the time where I lean into my colleagues. Like, it's time to phone a friend and put our heads together and really sit with the patient and try to figure out what the next course of action is. So from a midwifery standpoint, I'm always asking questions, trying to figure out what's least invasive. And then once we've kind of exhausted every skill that I have, I start to tag my colleagues.
Yeah, thank you for describing that. And then, Kris, can you go ahead and tell us how you would support this change and this shift? I know, again, communication was mentioned heavily in having these conversations with patients and bringing them along the journey. So how does a doula support birthing person moving through these changes of labor not progressing?
I, again, love asking questions, prefacing with questions. What does lack of progression mean? What are the, like, what's the barometer of like, this is what lack of progression means? Part of what started me in this work was I was induced with my first child, and it was a long process. And I remember, and I see this a lot, but knowing knowing the environment that you're in is important, and feeling safe in the environment you're in is important. And so creating for yourself and with the team around you a place where you feel like you can open up, feel like really matters. And I think that that's something to consider when we're talking about progress, and something that isn't talked about a whole lot, especially if you choose birth in a hospital and you're in a place where people who you don't know are in and out of the space. If you have any past trauma, specifically and especially sexual trauma, if we have, you know, males walking in and out of a space that we don't know, the cervix is a wondrous thing, and it protects us and protects our baby, and it also communicates, you know, so much of our body communicates when we feel okay and when we don't. And so I think it's important to, as much as we are paying attention to the medical indications, we're paying attention, and I am as a doula paying attention to the spiritual indications and the mental indications. Like, does my client feel like she or like this, like they can let go? With that, I also, if it's possible, I really do try to elevate the idea that it might be great to not do so many cervical checks, just so we can listen to our body and allow that to carry us, versus hey, you're 3 centimeters, which, oh my gosh, when you're in pain and you've been in it for a long time, it's so discouraging. So going back to what I was saying with being induced, I remember getting checked and not being where I thought I should be based on how I felt. Fast forward to my 3rd birth, I remember walking into a hospital and knowing that this baby was coming soon, and being checked and being a 3. And my midwife, who knew me very well, said, let her in. And I had that baby 30 minutes later. That happens. It also happens where our cervix can close up, can go backward. So really, again, as a doula, I'm checking in with you as a person, what you brought in here, what you're navigating while you're in here, and hoping to like protect the space to allow for openness and yeah, allow for openness.
Thank you for adding that. And I think that's something that we don't consider when we think about labor and birth progression, is safety, and this idea of perceived safety. Do I feel safe in this environment? Do I feel comfortable? And I think a lot of folks don't realize, you know, if you don't feel safe in the environment, so like you mentioned, if you have had some previous birth trauma or any type of hospital or medical trauma, your body may close up and actually reject the birth in progress. You could have been further along in your labor before you stepped foot in the hospital. And just your presence in that place can drastically shift how you're progressing. So again, something that we can plan for, something that we can talk about, and something that doulas and your entire care team can work together to help you feel more comfortable in your space. I know you can't modify the hospital a whole lot, but doulas and families are great at decorating rooms in the ways that they can, being able to dim lights or some things that folks like to do, to be able to help support them being more comfortable and supporting their body feeling safe so that they can progress through labor. I think all of these questions we've touched on a little bit, but we're gonna do a deep dive into each one of them. So we're talking about interventions. We've talked about inductions. How non-interventional can a midwife be versus an OB? And I think I want you to start out with that, Pam. How non-interventional can an OB be?
I think it depends on the patient. You know, I would love if every patient, you know, recognized the onset of labor, stayed home as long as their baby was moving until they absolutely couldn't take it anymore, came into the hospital, had, you know, one cervix check at admission, one cervix check at transition. This is getting really real. And then one cervix check, you're 10 and it's time to push. I mean, that's ideal for me. I love that. But needless to say, that does not happen all the time. So you know, the idea, I think, that it's very important, touching on everything that everybody has said, is the idea of team birthing. Team birthing is, you know, and for folks in the listening, you can go to saferbirth.org and understand what team birthing is. But in a nutshell, it's every conversation about me happens with me. So conversations of providers and nurses happen at the bedside before we make a decision about what we're going to do. So that actually, to Nicole's point, kind of stops the idea that someone's going to knock on the door and say, we need to check your cervix because the board says you're not changing. And you're like, wait a minute, who are you? What, you know, that kind of thing. So everything is happening in a more conversational, communicative fashion. So, and folks are in charge. Of course, we should always be asking, you know, can I check your cervix? And I saw Legina Greiner on here, who's a doula, and she had this mnemonic about, you know, you can always ask why, you can always choose not to give permission, you can always say not now, or you can say no, you can always talk about what are the risks and benefits of another cervix check, or rupturing membranes, or internal monitors. You can always have that conversation. The only time you can't have that conversation, of course, is in the setting of fetal distress, when essentially a lot of your, I think, autonomy is taken away out of necessity because we're trying to save a baby's life. So I would say, ideally, no intervention, but commonly as minimal interventions as possible with the consent of the patient. Those are the two ideals. Now, even though I'm saying sometimes interventions are necessary with the consent of the patient and the team's agreement, needless to say, sometimes that does not lead to, you know, success. Sometimes that leads to, yes, you have proven that I am in fact failing to progress and that I need to move to a C-section. And so there are many steps before the C-section. The push and pull between what Nicole as a midwife does and what an obstetrician does is, I think, with an OB managing your labor, you often have this feeling of this kind of watched pot. And if the pot doesn't boil quick enough, we're moving to C-section. And historically, that is true. I'm willing to admit, historically, that is true. When you put women in an ICU setting that is labor and delivery, and you have 5 surgeons managing their labor, there is no wonder that we have more C-sections.
Yeah.
I mean, it is the nature of the beast. But I will tell you very honestly, there are times when you need a surgeon. There are just times when every intervention in the world is not helping. That's all I'll say.
So thank you. Those are a couple really good points. The one that I want to just highlight again is you started out the conversation talking about how labor progresses. So labor starts, I stay at home, I labor, and then I go to the hospital just in time to push again. So Nicole, what do you have to say?
I will piggyback on the setting part of it. As a midwife, I'm gonna midwife very differently at a birth center or in someone's home than I would at the hospital, right? As far as being non-interventional, you're gonna have a little bit more space and time to wait for two reasons. One, because you're basically managing that labor on your own as a provider. But two, if a person is at home or in a birth center um, laboring or birthing, it's because they're low risk. It's because they're not having hypertension and diabetes and all of these other things that need to be managed in a hospital setting with a supervising physician. Does that make sense? And so, based on the setting, that's going to dictate how non-interventional as a midwife I can be. There are some interventions that, in the hospital, just per policy. And again, you may be in a hospital because you have a higher risk pregnancy. Things like electronic fetal monitoring, you might have to do, or they might suggest that you do continuous monitoring versus intermittent monitoring. But if you are walking into a hospital, laboring already as a very low risk individual, then we can do intermittent monitoring. We can maybe not do an IV catheter. Again, per the hospital policy, the midwife may really need to fight on your behalf for that because it really just depends. Because that one is really like a emergency thing. But as a midwife, I'm always thinking like, is this a risk or is this a thing that's happening right now? Right, we do a lot of things just based on what the risk could be. But for example, if someone comes in and they're 9 centimeters, I don't want the nurse struggling to put an IV in when we're ready to have a baby. Does that make sense? So as medical professionals, I think sometimes we have to think outside of, oh, this is the policy, so we just have to do it. Like the actual thing that is happening right now doesn't kind of negates the risk that you're trying to prevent. Because we can get an IV in after a person is birthed and get them emergency medication. There's so much staff, there's so much help there. So kind of being a birth protector in that sense as a midwife. And then safety is key. Also talking with my clients or members or patients that like I'm counseling you based on what is actually happening with you. Everybody wants a safe baby, a safe mom and baby at the end of all of this, right? And so sometimes, like Dr. Cobb said, we don't really have a whole lot of time to discuss, but we should take at least a moment and stop. Stop and discuss what's actually happening and get consent for that. So non-interventional wise, again, when you're not in the hospital, a little bit more autonomy there, but when you're in the hospital, sometimes the situation is going to kind of make you need to be a little bit more interventional.
Yeah, thank you for all of those points. Kris, did you have anything you wanted to add? Did you have something you want to add?
I was just going to drop the BRAIN acronym in the, oh, thanks, Genia. It's in there.
Okay. So that leads us to our next question. We've talked about birth plans a little bit. Birth plans are a little bit newer in terms of things that we found out and resources and ways that we can support birth. And I'd like there's some evidence showing that birth plans are associated with less interventions and better outcomes. So I'd like to talk a little bit about how OBs, midwives, and doulas consider birth plans, think about them, and how they work with them. I think we can start out with Kris. Can you jump us off with this question?
I can. So I call birth plans birth preferences. We prefer and we get to prefer all kinds of things for ourselves, for our families, for our births. And I think that we plan, right, for all of the ways that birth can express itself. And we have thorough conversations with our chosen care providers about what we prefer. And we find out if the things that we prefer line up with the care that we choose and the context that we choose to birth. So I think it's important to have preferences and to have plans. And once again, as we were talking about earlier, it's really important to prepare for the way that it might express itself, so that I think not only can we navigate our births in a safe way, but not just through the birth, but afterward. And I say safe as in we are able to be gracious to ourselves in the way that that unfolds. You know, it almost never goes exactly the way that we think. I mean, even to where, you know, you might think this is going to be the most painful experience of my life, and it turns out to not be. That happens for people. And I think birth can just catch you off guard. So, so if we prepare ahead of time, then we're able to give ourselves the grace that we need to navigate through. And it's really great to work with a doula in designing a plan. There's some really great resources out there, some templates out there as well. I know Atrium and Novant both have birth plan like PDFs on their websites. And I think it's important to read those just so you can see if you've chosen one of these places as your birthing place, to see what they even mention as an option. I know that when I work with clients, the amount of options that I present to them, they're always like, I didn't even know I could do that, or I didn't even know, you know, that was something that happened automatically in the hospital. I didn't even know that I could choose this. And so that's important. And then having also like addendums, if you will, like mental addendums to the plan, because if things do not go the way that you choose, say say a cesarean wasn't your idea of how you would give birth, but that is your story. And you want to have a clear drape in the room so that you can see your baby being born. Does the hospital even have those? I never want my clients to get into a space, any of us to get into a space and be like, whoa, like I thought I could have this and I thought I could do that, but I didn't, I couldn't. And I didn't have those conversations with my provider and with this space. And so I didn't know. So, yeah.
Thank you, Kris. So the doulas are really instrumental for helping us to start to think about birth plans, preferences, and options, as well as what's available to us in the various settings that we choose to give birth in. Nicole, did you want to jump in and let us know what you think about birth plans? I'm coming with a birth plan. What do you have to say to me?
I like how Chris put it as a birth preference, right?
Yeah.
Like one of the things I'm always checking for, because typically I start to talk to people about this in the third trimester, right? Now that we're preparing for birth at this 34 plus weeks, right? What do you want that to look like so that they can go back and do their research and sit with their partner and talk about the things that they might want to, actually have happen in their birth space. But on top of that, like talking about how fluid you are about this plan, about these preferences, because things can change pretty quickly. One thing that can change is very quick, that has nothing to do with a provider or a doula or anyone but the person who's giving birth, is that maybe you wanted to do this without medication and very quickly we learned that that's not the plan that you want. And so like how fluid are you with the birth plan that you have? And then expressing that also with your provider. The other way I go about, approaching someone's birth plan is respectfully, right? Sometimes things that are on there we're not familiar with or not used to. I think it's really important to ask questions when we don't know rather than passing judgment immediately, right? Because sometimes that's what happens in those spaces. So I usually try to kind of take a little bit of what my experiences have been out of it and like focus it on that member. And then also, if I'm asking questions, also providing education if necessary, right? There's one other thing about the birth plans right now is that a lot of the hospitals are doing most of the things that are on these manufactured birth plans, like skin to skin. We're usually going to encourage that immediately after birth. We're going to encourage delayed cord clamping. We're going to encourage a lot of things that are already placed into those birth plans. I think sometimes when I say that off the bat, you know, I'm sitting, I'm looking, I'm reading, and I cross off about 6 or 7 of those things and say, hey, these are things that we do already. It goes ahead and allows that person to kind of breathe and say, you know what? If that person was there putting up barriers, like I don't want them to do this and I don't want them to do this, that in my birth space, it may actually take down some of those barriers to say, hey, they are doing things that are evidence-based and also want my safety. So I try to approach it in a way that's like, you tell me first, and then I'll tell you what we're already doing, and then we'll make a plan around the other things that you would like.
Yeah. Thank you again. It's keeps coming back to the same thing for me. I think you all are saying we're saying the same thing over and over again. Communication is key. We all need to be communicating with one another and bringing the patients along with these decisions as things are happening and as things are progressing. Pam, I'm coming with a birth plan. How do you feel about that?
I
Birth
would say
preferences.
2 things about the birth plan. Prenatally, you come with your birth plan, and the provider, the person that discusses that with you, may not, in fact, be the provider delivering you. So that is a key distinction. So things that your provider in the office says, yeah, seems reasonable. Okay, sure. You can eat in labor up to 8 centimeters. Maybe eating and hydrating is really important to you. And then you get there, and the provider, either you've got hypertension, you've got preeclampsia, you've got something else. You could have a seizure when you have preeclampsia. Nobody's going to let you eat. Do you see what I'm saying? Things change. And so you have to, you know, can I labor with a hep lock in? Absolutely. According to me, some people not so comfortable with that. So a lot of times it entails not only having a conversation in the outpatient, but again, addressing those things on the inpatient without but Dr. told me I could, but Dr. Cobb told me I could, but Dr. Cobb told me I could. That doesn't behoove anybody. That makes the provider delivering you feel less than, or feel attacked, or feel it just you have to continually advocate and continually have a discussion. The other thing that I would say a lot of times is, again, the fluidity of a birth plan. One intervention sometimes begets another intervention. And so ultimately what your birth plan looks like, it might have to shift. You know, if mom is okay with Pitocin, you know, in general, active Pitocin requires continuous monitoring in general. So that means that if you're getting Pitocin, you've already conceded at least that you're not gonna be able to be off the monitor for significant amounts of time. It doesn't, but I might say to you, you have to be on the monitor, but yes, I'm fine with you in a chair. I'm fine with you on a birthing ball. I'm fine. We can continuously monitor in other places other than the bed. So it's little conversations like that allow mom to have continued autonomy and be heard and be seen without feeling like we've just torn up the birth plan. And therefore I'm very defeated and my experience is not what I want because my birth plan didn't match.
Thank you for adding that. And that's a really important point to consider, right? Is the provider that I'm talking to with my birth preferences and my birth plan actually going to be the provider that's delivering me? And considering some of those things, as well as how to have this conversation when we transition into this new space.
The only thing I would say is that's where your doula can be very helpful, right?
Exactly.
Your doula is present in both spaces. And
Yes.
so that kind of continuity and bringing up those conversations is helped by having that companion.
Yes. Yeah. And again, hopefully we're not having these discussions in the birth room. These discussions happened way before then. So we're not caught off guard. We're not confused in thinking that the provider that we've chosen might not be on call. We know that, and we've visited the other providers in the practice so that we see if we feel comfortable with them and if they will also honor the plans that we have for ourselves or the preferences that we express. that matters. It really matters that you feel comfortable and that you feel safe and you feel like you're going to be heard. And also that you're no matter how you're paying for this service, you're being served and you're a customer. It matters your experience, and folks work for and with you. I think that I'm gonna leave it right there.
Thank you for adding that. I'm noticing the time and we are at time. So I do want to pause to give you all some information as we move forward. We got some questions in the chat. We've been able to answer some of them, and in the Q&A feature, we've been able to answer some of them. But I want a pause and let Alicia do some housekeeping. And if you're able to stay and hang out, maybe we can answer those few questions in the next 5 or so minutes, if anybody wants to hang out with us.
All right. Well, on behalf of the Charlotte Maternal Child Health Work Group, we just want to say thank you so much to our panelists. If you can drop an emoji, a reaction, something to leave with them before you depart today in the chat. We are so grateful. Nicole, Kris, Pamela, and Racquel, thank you for holding space for us to learn and to converse and to think through some strategies moving forward. We are incredibly grateful for all that you've contributed today. Folks, please stay connected with the MCH work group. We will circulate, again, information to get you on that listserv. We'll send the recording out to you after the fact. And if there are other topics that you want us to hold space for, please send them our direction. Thank you so much. And we'll continue the conversation for those who are able to hang on. All right. Turn it back over to you, Racquel.
Thank you. And again, we're going to answer these questions, so they'll be available on the recording. So if you have to jump, now you'll be able to see them. So we got a question that came in. Is an induction recommended after dilation begins? When I arrived at the hospital, I had already started to dilate and with Pitocin progressed to delivery much faster than the attending physician anticipated. What should indicate to a provider that an induction is no longer indicated after one has been scheduled or planned? Nicole actually tapped in and answered that question. I'll read the answer, and then if anybody else, Pam or Kris, have anything to add, I think Pam may just have something to add. You can jump in. An induction should always be fluid. Often an induction is used to start labor, and then our bodies kind of kick in and physiological labor can take place. If you have a great labor pattern and your cervix is changing, this is an indication to hold off on intervention. Do you want to add something to that, Pam?
Nope, I agree wholeheartedly. I mean, if you showed up and you were already dilating and contracting, you were in labor. You were in early labor at that point. So an induction was not, quote unquote, necessary at that point.
Thank you. The next question, how does the manner in which healthcare providers communicate the decision to induce labor affect a patient's understanding, satisfaction, and perceived autonomy in the birth process? I think we touched on this a little bit, but does anybody have anything they want to add?
I love that question. I mean, I think that if your doc or your provider is saying you need to be induced, the first question is why and what now? Do you know what I mean? Why? If I choose to wait, what are the risks? Why are you suggesting this be done? Is it because, I said you want me to deliver, I want you to be my provider and I'm on call this day, therefore we need to induce you? I mean, is it something that frivolous, or is it something, why? First thing, what's the risk of waiting? And what method do you suggest based on what my cervix is? And how is that going to change my experience? The main thing I find people not realizing is that inductions take a long time. Mom has flown in, your husband's taken off work, and you weren't planning on being in the hospital for an extra 36 hours and not have a baby yet. An induction can take a long time, and people need to understand that it's not easy. I also, and I hate walking on labor and delivery and everybody's in the bed and getting induced, and we're just everybody's lying down, getting induced. It bothers me. I'm just like, labor should be an
Active.
active, moving process. It should be, something women are in control of. It is something that you experience, not something that happens to you. And I think we need to increase that. A lot of times an induction can take a very long time, and if you've got 8 rooms and everybody's being induced, it's just, I don't know. It's just not my perception of what labor and delivery should look like.
Thanks for adding that. And I think you brought out 2 really good points. One about laboring on the back and going in labor and delivering, and folks laying down to give birth is something that a lot of folks don't consider. My grandmother likes to tell me the story about how the first time she was strapped in a baby crib, essentially, because she was trying to climb out during labor and she spent days on her back and how difficult it was. And I'm like, it's probably because you was laying down. You were working against gravity. But I think that's something that a lot of folks don't consider. So thanks for bringing that up. I see you unmuted yourself, Nicole. Did you have something to add?
Yeah, I think if there's anything that people should take away from this, Dr. Cobb kind of hit on it, is that this shouldn't birth shouldn't be something that's happening to you,
Mhm.
right? So there's something called the Black Birthing Bill of Rights, or I might have said that incorrectly, but I think a lot of people, for one, it's their first time ever entering a hospital or medical space as a patient. And all of your life of being a patient, whether that be pediatrics or whatever the case may be, you're listening to what your physician, midwife, whoever, whatever they say is what's law, right? Birth is not that. And so you have rights around how this kind of goes. And so when Dr. Cobb is saying, and everyone else is saying brain, that's real. That means that you get to ask questions and not so much demand, but you get to hold people accountable to answer those questions in a way that you understand it and consent to.
If I
Yes,
can, oops, sorry.
go ahead. You have something to add,
If I
Kris?
can add to that.
Yes.
So with the BRAIN acronym from the very beginning, I've added an S, because Black people add S's to things anyways, but I added an S to it, and it is who will support me through this. And I mentioned that because, we can say all of those things. We can ask, what are the benefits? What are the risks? What are the alternatives? What is my intuition saying? What if I say no right now, right? Well, who's going to support me? And if I'm in that space and my provider challenges me, which happens a lot, I want to raise this and ask Dr. Cobb specifically, what do you do as a Black woman when you are in this space? You've been having productive conversations with your provider. Say your provider's not on call that day, and it's somebody in the practice who, you're cool with, but it wouldn't have been your first preference that was who was there that day. And things get challenging, and there's friction, and you don't want to be that angry Black woman. And also, you are you're going through, right? You're vulnerable. You're in this. You're busy. You're doing your work. You don't have time necessarily to fight. How do you fight? How, when you have your doula in the space, and you have your partner there in the space, and maybe your mother is there. I always give my clients information about, number one, we need to know who the charge nurse is, right? And who we can call if there's ever a situation. And that's something that I manage, right? I don't want a client in the middle of birthing worrying about, being hospitable. But just wondering, how do you navigate? How would you recommend a patient navigate that just kind of dismissal of what they're experiencing, and if that happens, and how to deal with when I've gone through the brain and I get to that S and I get to that support, and my provider might not want to or is not verbally supportive. How do I manage that? And how do I work with them?
That was a lot, Kris.
I'm sorry.
I mean, I think one of the things is exactly what I said. Conversations about me happen with me. Those conversations need to happen at the bedside. You know, those conversations aren't between the labor nurse and the provider in the break room, in the hallway, and they don't come in there as a united front where the patient feels like they're the enemy now. That's not what happens. It is, we're gonna have this conversation at the bedside. And I think it can diffuse that. I think that, I've never really been in a situation where someone was asking to make a complaint to the charge nurse or something in terms of that. I mean, when you birth with a practice. And if someone said, I don't want Dr. Cobb delivering me, that would be really hard to navigate because I'm the only doc on call for that delivery. And I got to call my partner in from home because this mom won't, which is her right. Yes. But that would be super delivery. And thank the Lord that has never happened to me. I think that it starts with a conversation though. And I think that there are times, I mean, I've had moms who wanted something that I perceived as either unsafe or unreasonable. And I had to be very open as I don't agree with this. And this is why I don't agree with this. And I think sometimes if you're just straight up, I had a patient, I had a patient, a Black woman who had a baby who had a problem and she just didn't want to be induced. She didn't want to be induced. And I kept talking to her, kept calling her. And she was like, you guys are so over the top. And I said, I am willing to concede that I might be being over cautious, but frankly, I think you're being under cautious. And she honestly responded to that. I was like, I'm willing to admit that maybe I'm being a little bit over the top, but you're not being. And she came in and she was trying to have a vaginal birth after a C-section. And she was on the birthing ball. And I kind of came in, I said, can I check your service? And she said, no. And I was like, okay, I'll be back in a couple hours. And she came back and she had a baby she had a baby. So she ultimately was right. But she said to me, no, I'm not getting off the birthing ball right now. Is everything okay? I'm not getting it off. And I was just like, okay. And I wanted to sign out and tell my partner, okay, she's 8 centimeters. And now I'm, I wanted to tag team. And she was like, it's not important what I am. If my baby is doing well, it's not important what my cervix is. And I was like, you are absolutely right. And it just.
But see here, Dr. Cobb, you feel like kin. You got that vibe. And so we can have those, those living room conversations in the birth space. But sometimes we are not in there with kin. And we've got our blazer on in birth. And so it's that navigating that environment that I have seen people struggle with. And I know as a doula, I bite my tongue, some of us don't, right? Some of us don't even find themselves in the hospital space anymore, right? Because they're like, I'm not even, but yeah, I wanted folks who are still here to hear just maybe if they find themselves in that kind of situation, where the support isn't where it should be, and the provider maybe isn't necessarily considerate of that person's experience in that moment, and or their choice, right? How do you deal with that? I think you answered really well, but also, hey, Dr. Cobb, everybody, like if you're looking for for someone to be supportive and to listen and challenge, right? Because we also need that. I find that really important in my work. I work with Black women and Black men, and I got to call us to stuff like, here's some things that we got to do if this is the result that we're looking for. This is not the way to get there. Or when we get to this space, like, how do we navigate that with grace? Like, these are important conversations for us to have for each other and with each other, surrounding our births, because there are there are things that we can do to help promote safety and our well-being and our dignity in these spaces. And we need to communicate with one another so that that's always elevated in our care.
Thank you for adding that, Kris. And again, big takeaway from here. I hope you guys are taking this big takeaway again. Communication is key. So communicating with all of your providers, communicating with your family, communication is key for everybody involved, and making sure that those lines are open. We're saying what we feel, we're saying what we know, we're being honest, and we're bringing people along the journey. So last question. Traumatic birth can have different implications. How can women be emotionally supported before and after, and how do providers support them? So this is something I think that everybody can answer, but I'd like to start out with you, Kris, because I feel like this is where we live as doulas.
It is where we live. It's hard, isn't it? A lot of us birth doulas Black birth doulas have either experienced trauma around our own births. It's a lot of the times what drives us into this work. We come from places, from people who have had traumatic birthing experiences, who maybe birthed us traumatically, right? In a traumatic environment. And I would say, even talking before, mentioning again these living room conversations, these family room conversations that we have in our communities with each other before we're even pregnant, to air out our stories. It's so important for us to breathe like life to what we hold in, and let folks hear us and support us. People who do love us and care for us. You'd be surprised how many people have experienced the very same thing, or also just need to hear somebody else say something out loud to give them voice. Have conversations with your mother, with your grandmother, if they are available, if they're still living, and they're willing to talk about it, contextually too. We are in America. What tragic, in so many ways, journey that Black women have trudged through on this soil. Even if you have not yourself birthed, the birth of this place and us here is a lot. And so it's important to air that and process it. Work with care providers who have done their processing, so that they don't process their traumatic experiences with yours. Mm-hmm. My births, the only thing I bring in with me when I go into someone else's birthing space is what has helped educate and will help empower your experience and protect. This is not my birth. And all of the providers of care, and I emphasize care, right? People throw out that word, care provider. Is this person actually caring for me? What does care feel like to me? That matters. So these providers of care, are they showing up for me, not living through their experiences, but with me in mind and being a witness? I don't even know what the question was anymore, but storytelling again.
Yeah, you definitely answered it. One thing that I want to highlight that you mentioned was having conversations with our families, and to remind everybody that we carry things in our wombs. It's our powerhouse. It's our center for creativity and life of all different sorts. And we carry the generational stories in our wombs too. You were in your mom's womb while she was in her grandmother's womb, in her grandmother's womb, in her grandmother's womb, and so on and so forth. So we carry those experiences too. So it's really important, like you said, Kris, that we continue to have these living room conversations or start having them. and have them across the generations. Find out what pregnancy, labor, and birth was like for our mom, for our aunts, for our grandmothers. Nicole, I see you've unmuted yourself. You have something you want to jump in and add?
Yeah, that traumatic birth experiences kind of fall into that social cup of like stress and anxiety will slow down labor, like
Yep.
something that's going to affect your labor. And so if we're identifying before labor even starts what some of the triggers are, we can maybe plan in advance to eliminate some of those triggers, whether it be, I don't want any males in my room for any reason. I don't want any students in my room for any reason. If I have to go back for something, I want my partner to be able to go with me. These are things that providers can share on like sticky notes and that sort of thing that is on your um, individual chart so that whoever is going to be there attending your birth will see these things and immediately say, okay, we have to change the plans. Now, granted, sometimes the only provider that's there that night is a male provider, but they'll walk into that birth space with the frame of mind that let me put an extra effort to make sure that I'm not doing anything that is going to make this person feel uneasy or harmed. Maybe we're not going to do as many cervical exams because that can be, traumatic, or maybe leaving the nurse if she's a female to do those exams. Of course, in the setting that things are going well and all of that sort of thing, but just kind of walking into the space with that sort of respect that I see that these are triggers that we've already identified. We're going to try to avoid them by all means.
Yeah.
And then, it's so funny we talked about inductions, but I've had situations where patients didn't want to see anybody but me. And so guess what? At 40 weeks, we did schedule that induction, and then I made a point to be there for that, labor and birth. Can't do that for everybody, but when there's situations like that, I have done that, or come in when someone is laboring. I say I'll be on call for you in specific situations. So it just really depends on who your provider is.
Thank you for adding that. And thank you for the ways that you show up and go above and beyond to show up for patients to make sure that they're comfortable. Did you have something you wanted to add, Pam?
No,
Okay. Thank you all for joining us today. Thank you for hanging back to discuss the rest of these questions. Thank you, Kris. Thank you, Pam. Thank you, Nicole, for each of the ways you all show up in our community to support birthing families and support birthing people having great outcomes and great experiences. And thank you for joining this conversation to share your wealth of knowledge with the community. We hope you all will stay connected and tune in for more conversations like this in the future. Everybody enjoy the rest of your weekend.
Thank you.